Welcome to this comprehensive medical learning session on acute airway obstruction and life-saving first aid techniques. When a choking emergency strikes, every single second counts. Oxygen deprivation can cause irreversible brain damage within just 4 to 6 minutes, which means that bystander intervention before emergency services arrive is frequently the difference between life and death. Notice our foundational imperative displayed prominently at the top. Act fast, save a life. Anyone, anywhere can make the difference. On the left, our clinical educator reminds us, knowing what to do in the first minutes can save a life, while on the right, our co-instructor highlights, be calm, act quickly, stay safe. Throughout this clinical visual masterclass, we will systematically examine how to rapidly recognize airway blockage, how to differentiate between mild and severe foreign body airway obstruction, and how to execute precise, evidence-based physical maneuvers for adults, children, pregnant individuals, and infants. We will also cover unconscious patient management, cardiopulmonary resuscitation modifications, preventive safety measures, and key clinical reminders. Pay close attention to every anatomical landmark and procedural directive as we build your emergency response confidence. Let us define precisely what choking is from a physiological standpoint. Choking occurs when a foreign object, such as a piece of food, a small toy, or a coin, becomes lodged in the pharynx, larynx, or trachea, physically obstructing airflow into the lungs. When the airway is partially or completely occluded, the individual is unable to move air effectively halting alveolar gas exchange. Notice the critical clinical distinction emphasized here. If the person cannot breathe, speak, or cough forcefully, you are dealing with a severe, complete airway blockage. In a partial obstruction, the patient may still be able to generate some air movement to produce a forceful cough. However, in a complete airway obstruction, no air movement occurs, atmospheric pressure cannot reach the alveoli, and oxygen saturation drops precipitously. This complete blockage triggers acute hypoxia and hypercapnia, leading rapidly to loss of consciousness and subsequent cardiac arrest if the obstruction is not mechanically dislodged. Understanding this mechanism reinforces why immediate physical intervention, rather than passive waiting, is clinical. Recognizing the signs of choking immediately is the foundational step of effective triage. Look at the primary behavioral indicator, universal distress signal, clutching the throat with one or both hands. This is an involuntary reflex driven by severe respiratory distress. Next, assess vocal capability. If the individual cannot speak or produce audible vocalizations, the vocal cords are unable to vibrate because no air is passing through the glottis. Evaluate coughing efficiency. A weak, ineffective cough or complete inability to cough indicates that thoracic pressure cannot build up behind the object. Watch for stridor, high-pitched whistling or wheezing sounds during forced inhalation, which signifies turbulent airflow forcing its way through a critically narrowed tracheal opening. Observe the skin color, cyanosis, seen as blue or dusky discoloration around the lips, face, and nail beds, reveals profound peripheral hypoxia due to deoxygenated hemoglobin accumulation. Finally, loss of consciousness is a late, catastrophic sign of cerebral hypoxia. Note the crucial rule at the bottom: if you are ever unsure, treat the emergency as a severe choking incident immediately. Now let us dissect the quick action flowchart that guides clinical decision-making during an acute episode. Step 1 is rapid assessment. Ask the patient, "Are you choking?" and determine whether they are coughing effectively. If the person is coughing forcefully, encourage them to continue coughing. A strong self-generated cough produces high intrathoracic pressure that is often superior to external force. However, Step 2 dictates, if they are not coughing effectively, cannot breathe, or possess a silent cough, you must instantly transition to physical intervention techniques suited to their age and condition. Step 3 addresses escalation. Call emergency medical services immediately if the foreign body remains impacted despite your physical interventions, or if the individual collapses into unconsciousness. Remember the overarching objective highlighted in the golden banner: one single goal, clear the airway and keep them alive. All actions must directly support restoring patency to the respiratory tree. Knowing when to activate professional emergency medical services is critical to preventing fatal outcomes. Let us systematically review the 4 absolute triggers for dialing emergency services immediately. First, if the person cannot breathe, speak, or cough, this indicates total occlusion requiring immediate high-tier medical backup while you perform physical maneuvers. Second, if you have performed the protocol-driven physical techniques and the object remains firmly wedged in the airway, professional surgical or laryngoscopic airway management may be necessary. Third, if at any point the person loses consciousness, instant dispatch of advanced life support is compulsory. Fourth, a special tactical directive: if you are alone with a choking infant, call emergency services right away or activate speakerphone while initiating care, because infant airway physiology decompensates rapidly. Dial your local emergency number, shown here as 999, immediately without hesitation. For conscious adults and children over 1 year of age experiencing complete airway obstruction, the gold standard physical maneuver is abdominal thrusts, commonly known as the Heimlich maneuver. Follow this step-by-step physical positioning. Step 1. Stand firmly behind the victim, position your feet in a stable stance to support their weight if they faint. Step 2. Make a solid fist with one hand and place the thumb side of your fist against the patient's abdomen, positioned precisely above the navel and well below the xiphoid process and lower ribcage. Step 3. Grasp your fist firmly with your opposite hand. Step 4. Deliver quick, forceful upward and inward thrusts into the abdomen. Biomechanically, this upward pressure forces the diaphragm sharply upward into the thoracic cavity, compressing the lungs and suddenly increasing intrathoracic air pressure. This sudden bolus of compressed air acts as an artificial cough, creating a pressure wave below the foreign object to expel it upward through the glottis. Step 5. Repeat these distinct thrusts continuously until the obstruction is forcefully ejected or the patient loses consciousness. Read the critical caution note: never perform abdominal thrusts on pregnant women or severely obese individuals due to risks of internal organ rupture. Use chest thrusts instead. When treating late-term pregnant patients or individuals with severe obesity, abdominal thrusts are contraindicated because anatomical distortion prevents effective subdiaphragmatic pressure and risks blunt abdominal or fetal trauma. In these clinical scenarios, perform chest thrusts. Step 1. Position yourself behind the individual, wrapping your arms beneath their armpits to encircle their chest securely. Step 2. Form a fist and place the thumb side against the lower half of the sternum, strictly avoiding the xiphoid process, and cup your fist with your second hand. Step 3. Deliver swift, powerful backward thrusts directed straight back toward the spine. This compresses the thoracic cage directly, rapidly increasing intrathoracic pressure without applying force to the abdominal cavity or gravid uterus. Continue executing sharp chest thrusts until the airway is cleared or the individual decompensates and loses consciousness. Infant airway anatomy requires a distinctly modified protocol because an infant's liver is relatively large and unprotected, making abdominal thrusts dangerous. For choking infants under 1 year, we execute cycles of 5 back blows and 5 chest thrusts. Phase 1. Deliver 5 back blows. Support the infant prone, face down along your forearm, resting your arm on your thigh for stabilization. Crucially, support the infant's jaw and head with your fingers without compressing soft neck tissues. Using the heel of your free hand, deliver up to 5 firm, distinct slaps directly between the scapulae. Combined gravity and impulse force work to dislodge the foreign body. Phase 2. If the object persists, give 5 chest thrusts. Carefully roll the infant supine, face up onto your opposite forearm, maintaining head support with your head lower than the trunk. Place 2 fingers on the lower half of the sternum, just below the intermammary nipple line. Compress the chest sharply down about 1.5 inches. Phase 3. Repeat continuous cycles of 5 back slaps and 5 chest thrusts. If the infant loses consciousness at any moment, cease slaps immediately, call emergency services. If a choking adult or child loses consciousness due to severe prolonged hypoxia, the primary airway management strategy transitions immediately to cardiopulmonary resuscitation with visual airway inspection. Step 1. Carefully lower the individual flat onto their back on a hard, firm surface to enable effective compressions. Step 2. Ensure emergency medical services are dispatched immediately. Step 3. Initiate high-quality CPR starting with chest compressions. Perform 30 deep chest compressions at a depth of at least 2 inches. Chest compressions generate artificial thoracic pressure that may force the foreign object upward toward the mouth. After 30 compressions, open the airway using the head tilt chin lift maneuver. Look into the mouth. If you clearly see the foreign object, remove it. However, if no object is visible, do not perform a blind finger sweep. Next, attempt 2 rescue breaths. If the chest does not rise, reposition the head and attempt rescue breaths again. Continue this uninterrupted cycle, 30 compressions, visual airway check, 2 rescue breaths, until emergency help arrives or the object is removed and breathing resumes. Managing an unconscious choking infant requires immediate protocol modification. First, call emergency services on speakerphone. Second, place the infant supine on a firm, elevated surface and begin modified infant CPR. Deliver 30 chest compressions using 2 fingers placed on the center of the sternum just below the nipple line, compressing to a depth of approximately 1.5 inches. Third, open the airway gently into a neutral sniffing position, look inside the mouth. If an object is visibly lying loose in the oral cavity, remove it carefully. Never sweep blindly with your fingers, as this risks pushing the object deeper into the narrow pediatric larynx. Fourth, deliver 2 gentle rescue breaths, watching for chest rise. Continue repeating the ratio of 30 compressions, visual inspection, and 2 rescue breaths continuously until advanced medical care takes over. Review these for vital safety guidelines to prevent secondary trauma during a choking crisis. Tip 1. Never perform blind finger sweeps in the oral cavity. Blindly inserting your fingers into a patient's mouth can inadvertently push a loose foreign object deeper into the posterior pharynx, transforming a partial blockage into a complete, fatal obstruction. Tip 2. Attempt removal only if the object is clearly visible and easily reachable. Tip 3. Do not delay action. Every second of acute airway occlusion deepens brain hypoxia. Tip 4. Even after the object is successfully expelled and normal breathing is restored, the patient must be evaluated at a medical facility. Physical maneuvers like abdominal thrusts or CPR can cause internal complications such as ribs fractures or abdominal organ injury. Furthermore, aspirated fragments may remain in the tracheobronchial tree, causing delayed pneumonitis or lung collapse. Prevention is the ultimate defense against foreign body airway obstruction. Let us examine the practical strategies to eliminate choking hazards in daily life. First, cut food into small, manageable pieces, particularly for young children and elderly individuals with dysphagia. Second, encourage thorough chewing before swallowing to facilitate a safe food bolus. Third, avoid talking, laughing, or running while chewing food, because vocalization opens the epiglottis, exposing the open glottis to aspirated food particles. Fourth, maintain strict environmental safety for pediatric environments. Keep small household items, coins, button batteries, and small toys out of reach. Button batteries present an additional chemical burn hazard if ingested or lodged in the esophagus. Fifth, ensure continuous adult supervision during children's meal times and play activities to intervene before an ingestion risk escalates. Understanding specific mechanical hazards allows us to proactively prevent dangerous obstructions. Inspect the 5 categorized high-risk vectors displayed here. Category 1. Food items such as whole peanuts, unchewed meat chunks, raw fruits, and firm candies. These easily conform to and block the pediatric airway. Category 2. Small household objects including miniature toys, loose coins, and loose components. Category 3. Hard candies and lollipops, which can accidentally slip past the back of the tongue during inhalation. Category 4. Uninflated or popped latex balloons. Latex is particularly deadly because its smooth, pliable surface creates a complete, airtight seal over the laryngeal inlet that is extremely difficult to dislodge with physical thrusts. Category 5. Pen caps, button batteries, and small magnets. As emphasized in the bottom banner, small objects can cause big problems. Vigilance across these high-risk items saves lives.